Welcome again to today's webinar on early lessons for effective and equitable contact tracing. My name is JB Wogan. I'm the host of Mathematica's podcast On the Evidence and a member of the communications team here. And I'm delighted to introduce our all-star panel to discuss successes, challenges, and early lessons in COVID-19 contact tracing programs. We'll be zeroing in particularly on what works to reach vulnerable communities, how to address COVID-related health disparities, and how to connect people with the appropriate support services through contact tracing. Let me introduce our panelists now. So we have Dr. Sandra Hernandez, who is the President and Chief Executive Officer of the California Healthcare Foundation and the former Director of Public Health for the City and County of San Francisco. As a philanthropic leader and a public health expert, she has been active in California communities, bringing awareness to the inequalities in healthcare for people of color during COVID-19. Welcome, Sandra.
Thank you, JB. It's nice to be with you.
We also have my colleague from Mathematica, Candice Miller. She is a senior researcher here at Mathematica, and she brings her years of experience in public health and social policy. Welcome, Candice. We're also joined by Elizabeth Odell, who is the Director of Medical Operations at La Clínica de la Raza, a community health organization with 35 service sites in the East Bay area of California and a 50-year history of providing culturally and linguistically appropriate services to diverse and medically underserved populations. And they are currently assisting with the contact tracing efforts in Alameda County, where Oakland is located. Welcome, Elizabeth. Finally, we have Marina Pravditch, who is the Manager for Communications, Policy, and Advocacy at the Rockefeller Foundation, where she focuses on advancing the foundation's policy priorities, including building community health workforces around the U.S. to contain the spread of COVID-19. Thanks to everyone for being on the panel today. I'm really excited to get this conversation started. So to start the conversation, Sandra, I hope you can take this one. Let's set the table by talking about what contact tracing is. Audiences might be familiar with the movie Contagion, which came out in 2011 and dramatizes some elements of contact tracing. But I have to confess that I personally was not familiar with the term until February, and now I see it and hear it in the news every day. So help us out. What is contact tracing, and why is it considered such an important component of the an effective response to the COVID-19 pandemic?
Sure, JB. So important to think about contact tracing in a larger toolbox of public health interventions when you're trying to control a disease outbreak. It really does start with testing because contact tracing really does need to be very linked to timely testing, so testing of people at risk, and then very promptly getting test results to a contact tracer. Contact tracer is essentially someone who gets notification of someone who is tested positive for COVID-19 in this case. And really, in a pandemic, doing this largely virtually or over the phone really tries to understand all of the potential contacts in family, community, and workplace that a given individual who's infected might have. Contact tracing then also connects to disease investigations and outbreaks. So think nursing homes, jails, prisons, congregate living situations where you might have an outbreak and a disease control investigator would, by virtue of a contact tracer, saying we should investigate this outbreak. And then very importantly, it needs to link where people are tested positive to isolation and then to quarantine for people who are exposed and awaiting test results. So it's really important to think about those in connection with one another and actually to build them in connection with one another, because any disconnect in any of those handoffs delays the time in which, precious time that you have, in essence, to stop further contagion of the virus. We focus very much on contact tracing, in large part because it's workforce intensive. It requires, if you will, boots on the ground. And over the last 2 to 3 decades, our public health infrastructure in this country has been vastly underfunded. Just to give you one data point briefly, California has 58 counties. Less than 25 of them at the beginning of this outbreak had anybody who did contact tracing for any condition. And so that is where we started in thinking about how we rapidly build up an effective and equitable contact tracing workforce.
Okay, so that is the value from a clinical perspective. Elizabeth, I was hoping you could speak to what it's like on the other end of the phone call, from your experience in East Bay, when someone receives a call about from a contact tracer. What is that like? What are the what is the just to tell me a little bit about what questions they're receiving. What is that conversation like between a contact tracer and the recipient of one of these calls?
Sure. So La Clínica began participating in more robust contact tracing beginning of July of this year, when Alameda County reached out to us and asked us to participate in a contract with them as a community partner to extend contact tracing efforts in our community because of the lack of resource that was really needed for contact tracing. So prior to our contract with the county, we were doing some preliminary contact tracing with our RNs where they would help to identify contacts. But now that we've built up this more robust program, we're really able to provide more in-depth contact tracing, case investigation, and then extend resources and help connect folks to additional support when needed. And so what I hear from our contact tracers and the folks that are doing the outreach to patients and community members with the positive COVID results is that oftentimes when they do get in touch with somebody, they are not quarantining, even though that was the guidance given. They are at work, they're on the bus, they are at church, and folks who receive this notice that they are positive and that they need to they need to be at home. It's really hard news to hear. It's a huge toll. We are working in communities that are already struggling, and a 2-week quarantine is often not realistic. And we are often talking with folks who are living in multifamily households. So even finding ways to isolate and separate from family is really challenging. So what ends up happening is if we have one member in a household who tests positive, it's really likely that the rest of the household will follow suit. So it's impacting people's ability to get to the store, pick up their paycheck, and wellness on multiple fronts is really impacted. And that's what our contact tracers are finding pretty much across the board when they're reaching out to folks.
Okay, thank you. I have to imagine, regardless of what your circumstances are, that it would be pretty scary and disruptive to your life to receive one of these phone calls. But are there any additional, I think, and you've just highlighted a few of these, but I just want to see if there's anything else you want to say in terms of additional considerations and concerns for vulnerable populations.
So, well, like I was saying, one of the considerations is that if they need to quarantine, how does that impact their work? Oftentimes, they don't have paid time off. And so we have community members and patients that we've reached out to who've told us, frankly, that they are not going to be following the quarantine guidelines because they simply can't. are the breadwinners for their family, or their household relies on their paycheck, and so it's not possible. And we do find for a lot of our patients that are testing positive that they are contracting the disease in their workplace. So food service, warehouse work are places where we find a lot of positive patients coming from.
JB,
Okay.
It's important, if I could, this is Sandra.
Yeah.
One thing that's important to point out here, and Elizabeth talked about the lack of paid sick leave, which many jobs, essential jobs, don't have paid sick leave. And that is a significant deterrent to contact tracing during this pandemic for sure. The other policy environment that is important to comment on is a very profound anti-immigrant policies emanating from the federal administration. And the way that plays out in the pandemic, this is contact tracing, as Elizabeth notes, is voluntary. You have to have trust that the information that you're giving to the person who's on the other end of that phone is not going to use that in any other nefarious way and threaten your family. And so not only are these multi-generational households, in California, they're often also family households by which there's mixed documentation status from an immigration point of view. And so issues like public charge in those environments are very chilling to effectiveness in establishing a trusting relationship with somebody on the other end of the phone. And that's particularly true if you're not speaking the same language, not have the same cultural norms and nuances that are important to do. So we didn't talk about it, but trust of the person on the other end of the phone, what information they're using, where it goes, in a very profound anti-immigrant policy background is a significant deterrent, I think, to effective contact tracing as well.
Yeah, that's actually a nice segue.
Sorry, JB,
Yeah,
just wanted to add, in addition to this idea that contact tracers should have the cultural awareness of the communities that they're serving, and if possible, be from the communities that they're also tracing. They wear so many different hats, right? So they're part detectives and like sort of case investigators. They're part therapists because it's hard to get this kind of news, and you really have to talk people through a traumatic experience, right, that you're relaying to them. And they're also part social workers, and that's maybe that last piece is maybe the most crucial piece, really, because their ability to be able to escalate the common themes they're hearing from their interviews and from their conversations to the relevant institutions that can hopefully help these people, whether it be with their job, while they're on sick leave, or whether it could be with evictions, whether it's honestly even things outside of just the COVID-19 pandemic, because many of these populations also have special needs outside of this context. That's really what makes a contact trace successful, really, and effective in their job.
Well, I think that segues nicely for the next question I wanted to ask, which is what is different about contact tracing with COVID-19 in 2020 compared to contact tracing as it's existed in as a public health tool in epidemiology in the past. Candice, you want to take that up? What's different about this? Oh, Candice, I can't hear you. Maybe you're on mute. Can others hear Candice? I can't hear her.
No, we can't. We can't hear you, Candice.
JB, maybe while Candice is getting her sound on, let me just make one really significant observation. I was director of health during the HIV epidemic, and doing contact tracing for an STI, sexually transmitted infection. You're getting information about sexual contacts, but there you're referring somebody for a treatment that exists. You've been exposed to syphilis you've been exposed to gonorrhea, or you've been exposed to whatever that might be. And it doesn't have the same impact as you're going to give a contact of a worker that works alongside you in a factory or in a warehouse. And that contact is also now going to have an economic impact of 2 weeks of quarantine potentially. So the nature of this virus and what we're asking people who are exposed to do is quite different than with other pathogens. And that is an onus that someone who's COVID positive and trying to disclose who their contacts are, particularly, coworkers or like, creates just a whole other dynamic with regard to hesitancy to have somebody else's economic livelihood, if you will, put on hold for 2 weeks of quarantine, say. I don't know if you're back, Candice.
I can see you talking. I can't hear you. All right. Well, we'll circle back with Candice as soon as possible. But well, I mean, so the with regards to the differences with COVID-19 and contact tracing this year, is part of it how widespread it is, how fast it's spreading? I mean, jurisdictional differences. What would you say is different compared to how we've tried to use contact tracing to respond to other diseases?
Well, I think a couple things. It is important to note that typically contact tracing is something that's done very locally. It's typically done by counties. Counties have, political infrastructures, boards of supervisors, county executives. In some cases, San Francisco has a mayor and a board of supervisors. And so these decisions about allocation resources and how quickly you recognize how important county partners are. So in Alameda, to acknowledge that a federally qualified health center like Elizabeth serves in, has multiple sites, is well trusted in the community, has a workforce that speaks the language of the communities that they serve. And so a county like Alameda can say, you're a longstanding partner of ours, can you stand up an effective contact tracing apparatus? That may be different in Orange County or in a rural county, for example. Mm-hmm. And so what you end up with is California, 58 counties doing these in very different ways. In San Francisco, which is where we started very early on in the statewide training for contact tracers, which the state is now providing the training capabilities for and the data collection infrastructure. But really these decisions about who to hire and how quickly you can hire are largely happening at a county level. And so even where you have an infrastructure like La Clínica, or in San Francisco, like Instituto Familiar de la Raza, which is a large mental health clinic that operates in the Mission District, where we've had a disproportionate outbreak of COVID-19 infection. These are organizations that, again, trusted relationships in the community, and the resources that they need, come via the feds through either FEMA or CDC. Then they come to the state. Then they eventually come to the counties. With this economic downturn, the counties are all now running in the red, and so they're displacing workers, and there's huge labor pressures, for example, to hire laid off county workers who may or may not have any ties to the existing communities that we're talking about trying to reach in a trusted, thoughtful way. So there's very complicated, both financially, how these programs are funded, to what kinds of decisions are made very locally to deploy resources, who do you train, and then if CBO, they still got to make sure that it gets into the county data system and gets into the state database in order for you to really understand the nature of the outbreak from a statewide perspective. So these are very complicated jurisdictional issues. and very importantly, very complicated flow of resources. If we do this, is it going to be matched? What sorts of funding is going to come in and backfill it? Many federally qualified centers across the state stepped up to do testing and got absolutely no resources to do that testing whatsoever, very low on the totem pole. And yet those are the types of organizations that are closest to the communities that have the most exposure and the most risks, as the data has clearly borne out.
Okay. First of all, Candice, do we have you back? Can we hear you?
I don't know if you can hear me.
Yes,
Yes, we can hear you. Good job.
All right.
We tested
All right,
everything. I don't know what happened. Thank you. Happy to be here.
This is the COVID era. These things happen. Okay. Well, so Sandra brought up data, and obviously mathematics, a lot about data and measurement. And so I was wondering how one measures success in contact tracing. And I mean that in terms of effectively reaching people, but also doing so in an equitable way. What do you think are the relevant metrics that are indicators of success, and particularly in the realm of vulnerable populations? Have you seen any promising practices from states and localities in tracking a state's efforts to reach people on the economic brink, or people who, for a variety of reasons, we're categorizing as vulnerable in this conversation?
Yeah, so I'm glad that you can hear me for this question, because I've been thinking so much about this and what does success mean in contact tracing during COVID? And, what is it about? What do we really want to do? We want to box it in and snuff it out, right? So contact tracing helps us box it in, snuff it out. And it means timeliness. So it means calling, getting test results within 24 hours of somebody being tested, and doing that case investigation right away, because you want to limit exposure, right? So any time that goes by between testing and having that result and doing that call is an issue. And there are database problems. There could be difficult or onerous manual processes as you go from testing to perhaps a state database to a local or a county database. There are bad telephone numbers, and this might be more common in vulnerable communities where people are less comfortable giving a phone number, or maybe the person doing the testing isn't taking the time they need with that person for whatever reason. So success really is reaching all of the cases, and that includes the hard to reach and vulnerable populations. And that means having these community-based approaches where you have people from the communities who are also part of contact tracing and case investigation. So you've got the right language, right? Any one of us could get a call this afternoon and say, you've been exposed. So what could get in the way of that and prevent success? If you don't have the right tone in your voice as you pick up the phone, if you don't communicate that you care about the person, if there isn't that trust right away, or there's a language barrier, any number of things could sort of get in the way of success. But success means having a high quality discussion where that contact tracer, that case investigator really understands where that person is coming from, speaks the language that the person speaks, is able to understand the exposure and the symptoms the person is struggling with, and what is getting in the way of them successfully isolating. So, or what is getting in the way of them, being able to protect other people in their home. So being successful means that you have to get the contacts, right? And this is a big issue. If I have to I work at a food processing plant, and if I tell you my contacts are all the people I work with, but maybe I just have a runny nose, can I go to work? So I might want to go to work and not tell you those contacts, but the person on the phone has to convince me that it's in my interest to help, box it in and snuff out COVID so that I'm not exposing other coworkers and I'm not going to expose their families and so forth. So those things are really important in keeping track of the metrics around how many calls are you doing within the 24 hours? What are the number of contacts that you're getting per case? And does that make sense? If you're getting too few, you're probably not doing the highest quality contact tracing. And then how much time do you call those contacts? So those things are all, those things are all very important, and that's about the case and the contact on the phone. But success is much more than that. It means that that information gets into a database. It's high quality data. There aren't mistakes. There aren't phone numbers that are incorrect so that the next contact can't be called. And that data has to get to local, county, state health departments so that the next steps can be taken. And that means that public health guidance and policies and decisions can be made from that data. And that means, right now, school committees and administrators across the country are saying, do we open? Can we open? How do we open? How do we do it safely? I want to know, as a school committee member, what does my local community look like? And because I don't live in an island, I need to know what the neighboring communities look like. And really what we see right now is each city or town or county, it's different. So the data is different. The quality and the level of information is different. And so we have a long way to go to be able to do effective contact tracing and case investigation in every call, and then make sure that that data gets back to where it needs to go. And it needs to go to decision makers, needs to go to government, but it needs to go to the public too, because the public can make better decisions about their behaviors and where they go if they know, for example, that there are certain places that tend to be where there is greater exposure. So stay away from the bars or stay away from some of the indoor places where there's exposure. And the one other thing, and I just want to highlight, Louisiana is a state that's doing this. They're noting where the highest number of outbreaks are coming from and the number of cases in those outbreaks, so that they know that food processing, industrial workplaces and bars and indoor restaurants are problematic places. So that says, well, the state needs to set up guidelines, or the local municipalities need to have guidelines. And then me as a person, where am I going to go Friday night? I mean, honestly, I'm obviously not going anywhere, but you should know that a bar is going to be a place where you might get exposed. So I think success means all those things.
Yeah, if I could add, JB, okay. I agree with everything Candice said, and I would put a little exclamation point behind transparency. Ideally, this is data you would have at a zip code level. So that, it's one of these things, if you don't measure it, you don't improve it. And so, the transparency aspect of this is incredibly important. New York has a very good dashboard on this. You can actually look at what they're doing at every phase from testing results all the way through isolation and quarantine. And I think when we get that kind of information, as Candice said, both policymakers and individuals and parents and families can make better decisions. I'll give you one quick example, though, that, Candice talked about this issue of, okay, there's an outbreak at a factory or at a bar. In California, Southern California, there was a couple of Airbnbs that continued to host these very large parties. And the mayor in Los Angeles said, if this continues, we're going to cut off electricity to those homes in order to stop those Airbnbs from having those kinds of gatherings. And the data that gave them that information is data that comes out of a contact tracing system. And so I think this question about accountability for behavior, whether it's businesses or Airbnbs or bars, is very important in order to make sure that those places that sort of say, we're just going to continue business as usual, don't, if the case investigation leads to the fact that you have repeat outbreaks in those settings.
So Elizabeth, Sandra mentioned something that caught my attention. She said it would be really important to have this data at the zip code level. And so I'm wondering, from the perspective of a community-based organization, as we're trying to collect more data, what influences our ability to do that well, and what resources does a community-based organization like yours need to improve the situation?
Mm-hmm. Yeah, that's great. We So here at La Clinica, we definitely value the data that is being gathered through all of this work. It helps us understand where we need to deploy our resources, helps us understand which households are at risk, and the data drives the policy, and the policy is what we need to help influence and influence change and improve the status in our community. And so for us, what we struggle with is our testing process is manual, our result process is manual, and so that means that all of the data collection and entry is a manual process. So we really need workforce to help us with the data management, and then also workforce to help with the data analysis. We're in 3 different counties, and like Sandra discussed, as well as Candice, that the reporting requirements amongst the counties is disparate, and so we have 3 different processes, plus reporting to the state, plus reporting to the federal government, and so it's we're drowning a little bit. And so I think having streamlined systems that we are in agreement about which data matters as best as possible, and then resource to help us have more less manual systems.
Okay, sorry, just taking myself off mute there. So I had a couple different questions.
Sorry, JB. I just wanted to also reinforce basically all the golden nuggets that all my esteemed colleagues have already mentioned. But this idea of interoperability of data is really, really crucial, I think. We're seeing that across the board, especially when you add a digital, tool as well to this, which, should always be just an add-on, right? It shouldn't be, human contact tracing cannot be replaced by digital tools. It should be a way to make human contact tracing more effective. But just wanted to mention that the piece of interoperability, which is very hard to do, right? Because there's like a technical aspect to it, which means that different systems need to speak to each other well, which, technology doesn't always do a great job at. It's also legal, right? We don't know what kind of data should we be able to collect, and how should we share it? And then, of course, ethical in regards to privacy, and how do we then, should we move that data around, and across what state lines or county lines, and ultimately what kind of data is it really going to be? Because we know very well that, especially demographic data, that a lot of contact tracers also hope to and strive to sometimes collect, so that it helps them with all these other things that we talked about, like wraparound services, all these other sort of supported social isolation issues. We know that they can be very mishandled very easily. So all of these things are really, really important. And I think that's one thing, in addition to everything else that everyone was talking about, I think we really, and especially because of, like Sandra very well illustrated, of the decentralized system, public health system that we have here in the U.S.
So can I add to that? And Marina, and I agree. I think some of these issues are complex, and I think sometimes states and even locally, talking to local public health nurse, there's so much fear around the data. And, in a lot of places where your local health department, they've been focused on health education, and, maybe they're involved in when there's a lice outbreak or something like that, but they're not doing a whole lot of, contact tracing in their daily life. And then, but at the state level too, where, this is obviously overwhelmed all of our state departments of health. And, I think it's easy to say the data is sensitive, so we're not going to release anything, or we're going to release too little for it to guide public health. And so I think really there needs to be a framework and parameters around how do you make sure that you're providing the aggregate information needed to make good decisions without using an excuse that we don't want to let out data that could be harmful. And of course, we don't want any kind of personally identifying information out there, but there's a lot of space between aggregate data for public health purposes and confidential data. And so I think we need to be clear about what is what, and not let that be an excuse for not having good data available at all levels.
JB, one thing that Marina and Candice raised that I think is really important, which is the public education around, just as we said, what is contact tracing, what are these time lags, what is disease investigation, what's isolation, what's quarantine, what's the difference, what are the implications. I mean, we started from zero, even understanding how this virus worked. It has a superpower that we all are aware of, which is, a quarter of folks have no symptoms whatsoever at a time when they're likely quite infectious. And so I think it's just really important to understand you have to have a very good public communication strategy that reaches into very unique communities, right? It needs to reach the Hmong community. It needs to reach the Spanish-speaking community. It needs to reach communities in trusted messages, but be broadly educational in nature. And that's another piece of this responsibility that, of course, at a federal level has been so murky and so challenging to sort through. And so, this has fallen largely to state leadership to try and do. And it's important to really understand both message and messenger in those public education campaigns. And that's a very critical public health function that we should not lose sight of. Maybe I should have started that before testing even. When do you test? And why would you test, right? And so I think the public education piece of this is a very important component part of it.
It's a great point. Well, and sorry,
I was just going to add. Okay, go ahead.
Go ahead. No, Candice.
No, I was just going to say the information that we're requesting is intimate, and you're asking me about my symptoms, you're asking me about my children, where have I been? That is intimate information to get over the phone for Americans aren't used to that kind of health interaction, right? Usually our health or our disease, our symptoms are private. That's something we keep private. It's not something we talk about. So that education around keeping your personal information safe is important. And, yeah, exactly. What does that mean to isolate? Well, what does that mean if I'm in the home and I don't have many rooms in my house? So that it is that education piece is so important for an American population that is just not used to infectious disease.
Okay, so I want to shift move to talk a little bit about best or promising practices and lessons learned. For example, Candice, you talked about what Louisiana is doing with being transparent and reporting out the location of outbreaks, which, I think it's fascinating that there is so much jurisdictional variation in terms of choosing what to report out, what to track. What are maybe, since Candice just spoke, maybe we'll go to Marina. What's an example of a best or promising practice, and then also maybe something that we're learning about how to do contact tracing well in terms of reaching vulnerable communities?
Sure. Thank you for that question. I always love to feature great examples. So we at the Rockefeller Foundation are supporting the city of Baltimore in their contact tracing program, which we launched in June. And it was sort of a multi-stakeholder initiative funded by different philanthropies. And, it's run by the Baltimore City Health Department. But in partnership with other community nonprofit organizations and different sort of public-private sector partnerships across the board, which I think is one sort of recipe for success is really to try to make it as broad as possible, because that helps then with this idea of public education and just inclusion, right? People feeling like they're really a part of this together and getting together to fight this, disease as a collective effort, which is something, as Candice already mentioned as well, is this idea of the collective is not necessarily in the mindset of, the American public. So I think that's that's something that, is, I think is starting to really happen as we speak, but, it's still this individualistic culture of this country is something that makes it harder in a situation like this, but also what makes it beautiful. So, in my humble opinion, as an immigrant. So, but to go back to Baltimore, it's what is sort of very innovative about that project is that it really it's both addressing the public health crisis, but it's also addressing the economic recovery that this city really will be and is in dire need of in this crisis by hiring people directly from the communities that they would be doing contact tracing in, who have been laid off or lost their jobs due to the COVID-19 crisis, and are now being trained and given these skills as public health community workers, so that they can do effective contact tracing with people they know, right, who speak the same language, that are sort of understand the culture. So the project is just starting, really. We're currently in the stages of hiring and deploying this workforce, but we're really excited to see what will happen, and it's going to stand up about a little more than 300 contact tracers in the city, which will then work with sort of the hardest hit communities. It's supposed to run for about a year. And then in order to sort of try to make this as sustainable as possible, throughout that year, these people will also have abilities to develop, their career skills, so that hopefully once that year is up, they can find jobs elsewhere or in the public health, context, which they will be able to do because also of all these different partners that will be a part of this effort.
Elizabeth, in terms of California, I know California and Massachusetts are two of the states that kind of started contact tracing earlier than other parts of the country. Any best or at least promising practices you're seeing in contact tracing, and in particular in terms of what we're learning about how to effectively reach vulnerable populations?
Thanks for that question. So like has been mentioned before, our clinics are based in the neighborhoods and communities that we serve, and our staff, we hire our staff from the communities that we serve. So many of our staff are patients or former patients, or their family members are, and we hire staff that are linguistically and culturally trained and are able to connect and communicate with our patients on multiple levels. And so I think that for us has been a key ingredient, and I can't imagine how we would have had an effective program without that. And I think also having a multidisciplinary team where we have clinical leadership, we have frontline staff, and we have a county partnership that we are in constant communication with, and problem solving and debriefing and identifying ways to reach out and to connect to our patients. So I think those are two of our key ingredients that we found to be essential.
JB, if I could build on that, Sandra.
Please.
California, under the leadership of the Newsom administration, built a program called Project Room Key. And in the spirit of both kind of what have we learned from that program and what, pivots we're making in response to what we've learned, I think there are a couple of lessons. The program with state and federal dollars essentially rented out hotels and motels, and then staffed them with the ability to bring in medical monitoring, food, so that people who could not safely isolate at home, or maybe didn't have a home, would have a safe place to go and isolate where they could be appropriately monitored and cared for. Sort of speaking to the social work aspect of this that I think Marina mentioned earlier. And interestingly enough, the uptake in the Room Keep program has been modest. And it's actually created some political tensions because California, of course, pre-pandemic, really had a very large unsheltered population, homeless populations. And so you have this situation where you have these rooms that have been set aside for COVID isolation, and you've got people on the streets that aren't yet COVID positive. And so there's a lot of pressure around sort of vacancies of these rooms and highest and best use of them. But I think what we've learned from folks that we've offered those to is that they would rather take those resources and stay in whatever their housing situation is. And so I think what we're beginning to see now is care packages where you get hand sanitizers and you get a pulse oximeter and you get a thermometer and you get fresh hand towels, and you really try to create as much of the capability within these multi-generational households. I mean, imagine, you're the caretaker for your mother and your 3-year-old daughter and you're COVID positive. So, you going out to a hotel for 2 weeks, even with support, just is not feasible. It's just not going to happen. And so I think those are the kinds of things we've learned from those programs. And now there's some experimentation even in paying people 2 weeks' salary or a stipend, if you will, to offset the economic loss of having to go to an essential job that if you don't show up to, you won't have tomorrow or post your COVID illness. So, I think it's important to learn rapidly from programs that we have built and really pivot and try different vehicles. One of the big issues we've heard in California on contact tracing, for example, in our farm worker and agricultural workers, is that so many of them can't afford to pay their phone bill, their cell phones. And so, if you're trying to reach somebody whose phone is disconnected because they can't afford to pay their phone bills, those are the kinds of economic conundrums that we find ourselves when we're really trying to look at equity and how we really do contain this virus in very poor communities that have these very tough trade-offs. Even if you want to cooperate and want to be, do the right thing, sometimes those economic situations really require that the state think about doing things quite differently than we would otherwise. So innovation is important and rapid learning is more important in some ways to just try to understand what works and what doesn't in different communities and in different sectors. In terms of business sectors, they have really different aspects associated with them.
Candice, before you go, because we've sort of gone around, I want to hear what you have to say in terms of a promising or best practice in reaching communities. But I'd like to put a finer point on it. Hopefully you can answer this. But it strikes me that there is this tension or balance that needs to be struck in terms of moving fast to, as you said, kind of snuff it out. But at the same time, you have to build trust, and that can take time. So are there any tips for jurisdictions or CBOs or states that are trying to get that balance right? And I liked what Elizabeth, I think, had said about hiring from the community. I think that's something I've read in some of the news coverage from NPR about this. But do you have any other any tips that should be on the top of audiences' minds?
Yes, I think just to sort of piggyback on what Marina and Liz had said, in hiring local. Once we had community health workers who were contact tracers or case investigators from those locations, things were so much easier. We could really have that. There was local conversation that went on, right? So if I'm in that community and somebody called me and I had a good experience, that message got out, and those community health workers helped get that message out. So having, people from the community, so important. And that, I really do think that we need so much more of a media presence to myth bust help sensitize the public and, government agencies to what is effective contact tracing. So I don't know if foundation partners or anybody can help with that, states can help with that, but, starting with that, I think that is really important. And then in these projects, making sure you are hiring local. Yesterday for the state of Washington, we did a training for new supervisors, and similar to in Baltimore, some of those new supervisors, just great folks who've been laid off from their positions because of COVID. And, they are so passionate and committed and caring and really want to be part of the solution and part of boxing it in and snuffing it out. So we have a community partnership council that we're building in the state of Washington, and our local partner, Comagine Health, they are reaching out to all their partnerships. They have a lot of community-based primary care facility, different types of relationships and partnerships, and they're reaching out to all of them, tribal leaders and so forth, and inviting ambassadors from those organizations to join us. And we're going to have listening sessions and times where we come together, hear about what's happening locally, and problem solve. How do we get to that, that agrarian group that are living very close together, but we know there's an outbreak in their, in where they're living. So I think that's something I'm really excited about, and that is based on learning that, nothing about us without us. Make sure you have those local voices and relationships in order to be successful. And I think there's so much work that goes into sensitizing and to establishing a relationship that happens way before you first make that contact tracing call. So laying that foundation for success, I think, is really important, and it's going to reduce the number of times you have to try and call back and you get no answer. So I think those types of things are helpful.
JB, if I could just build on that for a moment.
Actually, we only have a few minutes before the audience Q&A. So maybe you can incorporate this into your answer, but I wanted to give each person an opportunity to briefly say, if you could leave the audience with just one key to designing an effective equitable contact tracing program, what would that be? And when I say brief, I mean, if you can try to do it in about a minute so we can get to everyone, I'd love to that do the last thing we talk about before we tee up the audience. Dr. Hernandez, do you want to start us off?
Well, I would say the answer is build trust. That's unequivocally the most important part of all of these pieces. Trust in the data, trust in your public health officials, trust in the person who calls you on the phone, trust that you'll do the right thing with the data, trust that people will provide accurate data and make it publicly available, trust in what they're learning and the public health messages. I think that's the biggest piece.
Marina, do you want to go next?
Sure. Since trust was going to be my message too, I will go with speed, because I think as everyone has already said, if we don't get the test results back quickly, to then be able to get them to contact tracers so that they can trace those people who were exposed, and then so that they can then also alert the people they have been in contact with. It's all for naught, or it's just not going to be as effective as it should be. And so, this really has to happen from the very beginning of how the test is administered, whether people have access to it, and then from then on, all the other moving pieces have to also come together. So that's my.
Okay. Elizabeth, what do you got?
So I completely agree. Trust, speed, those are the cornerstones. And then along with that, policy that would support those efforts, driven by our local officials, our statewide officials, and the federal government as well.
Okay.
Shall I add?
Yes, please do. Sorry.
No problem.
Yeah.
Okay, so given all of those
technical difficulties. Sorry about that.
I've had mine.
Go ahead.
given all of those things, absolutely agree with those. But that I appreciate that, because it opens up the door for me to put in another data plug, because I have been on the side of looking at the data, a contact tracing database and case investigation database, and seeing all of this information that could help local, regional, national, state, everybody so much if we got that data out for public consumption. So I think we as a community, whether it's local health departments, state health departments, we need to really focus on getting that information out. And I know I've said it before, but really we could get out of this faster if we could use our data better.
All right, so we're going to move to audience Q&A, although as I was saying, I'm having technical difficulties. I've accidentally closed out the window that, to see the Q&A. Brian, if you're still on the call.
No problem. What you need to do is go to the bottom of your screen. It says Setup, Live View Preview, Q&A. Tap that Q&A tab and your window will appear. And then select Questions.
All right. Do any of the panelists know examples where tracer programs have commitment from their local counties to hire tracers into county jobs after the temp tracer jobs end?
That's a great question. If I could, JB, there is a large collaborative of funders in California that has an agreement with the state to do just that. The state administration is very interested in a long-term view of hiring these positions as an economic engine in low-income communities as part of their equity agenda. And I think it is important for us not to just see this as we're going to try to battle COVID right now and then let all these workers go. Really what you want to do is build those skills and create an economic ladder into these jobs so that our public health departments across the country look more like these communities that are currently most heavily impacted by COVID, as we've seen all across the country. So I think it's a great question. The philanthropic organizations are working with a national not-for-profit who will do the identification and the training and the connectivity. And the idea is to look at that as a long-term economic driver.
Okay, I've got another question that actually would be perfect for you, Dr. Hernandez. What role, and I think Candice actually referenced this at the end of her remarks, but what role can philanthropy play in supporting contact tracing efforts, especially in light of our conversation about gaps and barriers to serving vulnerable populations? And I suppose, maybe one kind of nuance here is, are there differences between the role of, say, a local community-based foundation and then regional or national foundations, or foundations with a regional or national focus?
Well, let me just say, first of all, in California, I mean, we have a very rich philanthropic sector, from the corporate sector to, private family foundations to robust community foundations to, half a dozen healthcare foundations. And what's been striking here is that all the philanthropic community, whether they're in the health sector or not, have said, how do we participate in a meaningful way to scale up contact tracing to meet the needs of the communities that are most underserved currently. And so, pitching into a pooled fund is what is happening in California. That's been organized and set up. It's in partnership with the California Department of Public Health. And importantly, the counties themselves need to be active participants in this. You can't do it without the counties, but you also can't do it with the communities most impacted. So those are good examples. And, there may be LA funders who say, we're going to pitch into the pool of funds. Can you make sure our dollars target LA? No problem. You can do that. You're a California Healthcare Foundation, as we are. We want to make sure that our dollars are, filling in gaps where there isn't a philanthropic engine that can be helpful there. And then really working closely with the state to make sure the FEMA dollars and the CDC dollars, if those all fit hand in glove with the philanthropic dollars. There's no way philanthropy can pay for all of this. But philanthropic institutions have been working on economic development and working on health equity and have grantees that already are well situated to provide these kinds of services. So the ability to sort of say, here are the organizations in this region who have this capacity to do this hiring and do that kind of training, so that those dollars can be rapidly deployed to organizations that have community-based relationships and credibility and infrastructure to be able to do the kinds of things we've been talking about.
Okay. And Jamie, if I can just add a couple of points too. So to completely agree with Sandra, I think philanthropy really can't replace government, as she already alluded. I think too, we, as philanthropic organizations, we have obviously funds that we can give out, and we do, but we don't have that kind of a large mandate, and we don't have those kinds of finances. So I think what philanthropies can do really efficiently or effectively is take unique risks that maybe governments are not able to or are not willing to, and then of course to advocate with governments on behalf of our grantees and our efforts for policies and for just issues that we care about, I think in that way this sort of this ability to have like a convening of so many different minds is something that philanthropies can do really well. Academics, the academic sector, the public sector, the tech sector, all these different sort of stakeholders and actors that need to come together to really come up with a real solution to this really far-sweeping problem that we're in right now.
Liz, this question
role that we didn't mention, JB, on that is I think there's an important role when we know something works to disseminate that so others can take it up, and that's always an important role for philanthropy. Telling the stories of it worked here. Here were the component parts, and then just do rapid cycle evaluation. I think that's also really important. The other tool that we didn't talk about is polling. Sometimes you can help just understand what public sentiment is in a particular place, do that independent of government, and that does create some accountability capabilities, which I also think is an important role for the philanthropic sector to be able to play.
Okay, perfect. Thank you for that additional insight. Liz, this question I think might be well suited for you. What's one thing that government or foundations could do right now to better support community health providers as they continue to confront COVID-19?
Well, I think they can support us with the education piece, community education for community members around how to keep one another safe, how to keep themselves safe, and then what the difference is between quarantine and isolation, the importance of doing that, providing support, financial support for those that need it in order to complete isolation and quarantining when it's needed. I do know here in Alameda, we recently, our Board of Supervisors did approve a stipend for folks that qualify for, I think it's $1,250 a month to be able to support them in being able to quarantine when they need to. So I think also job training and for supervisors and workers around how to keep each other safe in the workplace with physical distancing, proper mask wearing. And so those are some key things that I think we would really appreciate support from our local government.
Okay. One question, this may speak to jurisdictional variation, I don't know. Is there a standard questionnaire for contact tracing? Are all states, all counties cribbing from the same template?
So I can speak to this. I think there's wide variation. And, it depends if there is a state level response, and it depends if every local agency is buying into that. In many cases, they're not. One of the places where there's a lot of variation is in care support. So for example, you're going to do a home assessment and a support assessment if you're actually going to provide some kind of supports to people. So you're not necessarily going to ask about, do you need food to stay home and isolate, if you're not going to provide it. So those are some of the different variations. And I don't know that it needs to be the same, across different places, but you want to have quality across different places. And if you're getting low response on the contacts, that's something that you want to look into in your script, because maybe you're asking the questions in a way that you just aren't going to get the response that you want to get. So I would say there are incredible differences across states and across localities in the scripts, in the data systems that are being used, in the length of time that all of these processes occur, and then what happens with the data afterwards. So it's not a coordinated effort at this point, certainly across our country.
Okay. This is a question that I think touches on a few of your comments earlier in the panel, but this person asks, would love to hear about any insights regarding multi-generational / high-density households, especially for the farm worker / food industry worker families. Are there any best practices or anything we're learning so far about how to get contact tracing right for people for people we're reaching out to in those communities?
So I can start with that one, and really anecdotes. Certainly when we were finding a lot of families where there were, maybe there was a mom who was working in nursing homes. She was a CNA working at multiple nursing homes. She having a husband, having children in the home, also having parents. And, I remember one in particular where the mother was positive and trying very hard to care for people, but not expose others. And so, the work there was getting her the gloves, getting her whatever she could do to sanitize, getting food, trying to figure out within the home, and the contact tracers on the phone trying to think through, okay, so what can you do within the home to keep separate? And okay, we understand you're going to stay with your baby. Your baby's going to stay there, even though they might be exposed, but there was nobody else who could take care of the baby. And so just sort of every little detail of how do we help try and keep this family safe. Those kinds of things were, they're just constant.
Okay. Does anyone else have something they want to add on, for multi-generational households, high density households?
Well, one population we haven't talked a lot about are farm workers and our agricultural workers. And in California, of course, that's a big industry, and a lot of families that have very difficult transportation issues, very dense housing issues. We already talked about mixed documentation status. And really what's going on in California right now are some early studies trying to understand, and again, doing these with local federally qualified health centers who in many cases are the source of primary care and medical care serving these populations. Really just to try to understand, first of all, what the incidence and prevalence is, what the housing circumstances are, and what their needs are for isolating and for quarantine, and because they're quite unique. And so, to Candice's point, this is certainly not a one-size-fits-all. You really have to understand the population that you're serving, and in many cases, trying to understand what is the best way when you have a COVID case identified to really protect their coworkers and their family members, given the unique situations that they live in, often not having any private transportation, et cetera. So I think we still have a lot to learn, and I don't think there's many effective anecdotes that we could answer today, but I think there are people certainly leaning into understanding that situation better.
Let's see. There's a question here about children. That's one vulnerable population that we haven't, I think, spoken about directly yet. Is there anything that we're learning about contact tracing efforts in terms of reaching not just the adults, but also getting information about the entire family and the children, and making sure that the children are kept safe?
Well, I would make a couple of comments on this. First, we haven't talked about this, but if you look at the epidemiology of this virus and you try to understand where the virus actually creates diseases and how it gets into the respiratory tract and the like, while not 100%, it does seem that children under the age of 10 do not have the same number of receptor sites for the SARS-CoV-2 virus that people do after that age break. This is data that we've seen from Europe and from China and elsewhere. And so, again, while not foolproof, and there's certainly, examples of young children who have died of this virus, but it isn't, most of those children have some pre-existing condition that predisposes them to having a poor outcome related to it. What we're still learning is how infectious kids are. So if you're a child living in a household where 2 or 3 adults have COVID, even if they may not be themselves at such risk, what's the likelihood of their being able to transmit it? They're smaller in size. These are large size droplets. And there are a lot of pieces of data epidemiologically that would suggest that under the age of 10, the risk of transmission is significantly less, but not none. And then the other point I would make that we're alluding to here, go ahead, Candice, you want to comment on that?
No, it just, I think with schools opening, I think this is one of our sort of major failures. I don't know if people saw that Washington Post article from earlier in the week, where teachers had started doing contact tracing, and really because there isn't data available all over the place, it's really from the media. So they have pulled together state by state where the outbreaks have been in schools, and the cases and the contacts, and teachers put this together. And so that is sort of our the best information I've seen on children transmitting. And I think, we know that some summer camps were open. Really, though, the major spread among children is really poised to happen in the fall as more and more schools reopen and we learn more about the sort of path that the virus takes and how we're going to do contact tracing in these in the school setting. I am very concerned about this situation, and agree, Sandra, with some the data. What we're learning is very important and great, that children under 10 don't appear to have the the morbidity that others have, but they may have higher viral loads, which is for adults in those school buildings extremely concerning. So I feel like it's going to be a rocky fall, a scary fall for many people.
Yeah, I agree with that. I guess, the notion of creating pods of students really is to allow you to do better contact tracing. Same adults working with small groups of children, so that somebody is positive, you're not having to do contact tracing for an entire school. So I think a lot of these recommendations about how to try to safely start back at school is with the idea of how you would do contact tracing in the event that you had a case. And I think that's important. But the other thing we should not lose sight of is businesses are going to be doing contact tracing, schools are going to be doing contact tracing, colleges are going to be doing contact tracing. Contact tracing is no longer going to be solely the purview of local health departments. And so to Candice's long-standing point on this webinar, how does all that data come together in a way that actually still informs the local health department? Because everybody's going to get into this contact tracing business in a way that we've never seen before. And I think the reopening of schools we are going to see that, and there's going to be just a ton of things we don't yet know and that we will need to learn about that. And Candice's point that you've got an infrastructure doing contact tracing that's exhausted, right? This virus is still beating us. We are not winning this war. And the people that have been at it every day are tired. They're fatigued. And so this, again, just speaks to the vast inadequacy in our public health infrastructure at the outset of this pandemic. And if we take away nothing as a policy matter, if in the middle of COVID-19 as a pandemic, we don't recognize that we as a country need to invest long-term in public health, we have missed our moment. If not now, never. And so this is a really important piece because, as Candice says, this workforce is exhausted, inadequate, being retrained, learning on the job, and we're asking for, better and more transparent data, which we absolutely should be doing.
We have a question about workforces. I know we touched on this a little bit, hiring, local hiring, but this person asks, different states, counties, and localities are taking different approaches, very different approaches to how they're staffing their contact tracing operations. What do we know about the impact of who is hired and how they are trained to do this work? And what are the specific implications for how to effectively reach vulnerable communities? I know California has taken a very different approach from Washington State, for example. It's something I've read about. Does anyone speak to the variation and what seems to be working in terms of hiring and training?
So I don't think, I would add to what Sandra said that traumatized too, tired, overwhelmed, and people doing contact tracing are also traumatized. And I think that's important because I think, it's hard to do new things. It's hard to train. It's hard to do anything when there is trauma. And this has caused trauma within health professionals all over the place. I would say that evaluation is something that is not happening in contact tracing, right? In terms of evaluating the training program as an implementer, when you're working with contact tracers, you're sort of maybe doing some monitoring and you're sort of taking a little small evaluation approach, but evaluating really what is a best practice, what really works. There are different course modules and stuff, and I think that's great. I think any kind of public education is important, but are those effectively, are they really a high quality course to train people to actually go implement? I don't think there's any evaluation of that. And I think overall, evaluation of a state approach, a county approach, a community-based approach, there are businesses doing contact tracing. Are they doing it well? How are they doing it? Well, there's really no evaluation. Right now, it's just, let's do what we can. And I think, that's an area where probably foundations could help out, not only in coming up with, a best practice and a model that other states or other counties could adopt, but helping to evaluate so that we can figure out what is working. Because, unfortunately, this COVID seems to be with us for a while. And lessons from now could help us get out of this faster and inform future public health efforts. Because you look at the experts, and COVID got us this time, but there could be something around the corner, in however many years that we want to address quickly and a lot faster than we've been doing with this one.
Well, one thing that we know is around the corner is the flu season. And one person asks, with the surge expected in COVID with the onset of both the cold and flu seasons, how are contact tracing strategies being updated to be more efficient and effective compared to the last few months? What's going to have to change to prepare for this or the co-occurring flu and COVID seasons?
Separating these two is going to be very, very difficult, right? If you're doing a case investigation, the symptoms for flu and the symptoms for COVID are just going to be difficult, right? There's going to be a lot of kids who are out of school because they have a symptom, whether it's a runny nose, ragweed, allergies, or flu. Most importantly, though, we want kids to stay home if they are ill because we don't want to transmit COVID. But if we had a really robust testing across our country, across each state, then we would have a better sense of that, right? We wouldn't have to do sort of stay home when you only have a ragweed allergy. But without that, it's hard. I mean, I don't know what others think, but I don't know how we're going to separate flu from COVID and contact tracing.
Yeah, if I could just add on to that, I agree. I do think early and comprehensive flu vaccination is hugely important. And so that is really a significant recommendation in terms of reducing hospital surge capacity and capability to manage COVID, number one. Number two, kids are a major transmitter of the flu. And so one of the things we don't yet know is with all these kids that are doing online education and not circulating out there, will we actually have less flu being transmitted? That all being said, Candice's point about testing is a valid one. We haven't talked about pooled testing. That's another way in a resource-constrained environment where test turnaround time is challenging and the like. In the school settings where you can, confine students to a group, you could do pooled testing. If they're negative, they're all negative. If they're positive, then you have to test everybody. So I think we're going to have to be innovative about our testing capabilities in these innovative school settings that we're building, evaluate them and understand them, really aggressively promote the flu vaccine, particularly for the populations that are most at risk for flu. And I think all of that is, I have to say we're going to get caught up in the, well, isn't COVID just like the flu? Well, the answer is it isn't. And we need to make sure that we keep our public health messages accurate with regard to what we know about flu and what we know and are continuing to learn about COVID.
And just to mention, JB, just wanted to also piggyback on this point about testing. We at the Rockefeller Foundation really sort of found this to be the cornerstone of our strategy on how to, have our small sort of contribution to this national, crisis. And it's really this idea that we need to increase and improve our testing capabilities. In comparison to many other countries in the world, we're really not there yet. And this includes diagnostic and also screening testing, right, which is slightly less accurate, but can then lead you to more accuracy once you have that result, right? So those are all such important things and issues that we need to, as a country, be better at. And just about this point on flu and on the flu and COVID in the fall, I think we're really going to have to have consistent messaging that is also flexible, right? That we can change as things move. So this is why this public health crisis has been so unique and in some ways difficult too, is because it's really changing rapidly, and that's making this like public communications, public education campaign piece very difficult. We've talked about this a little bit before as well, but we really hear not only from the general public, that they're sort of, that they don't really know what they should be doing right now. But we're also hearing this from public health officials who are also at a loss, right? Because at first it was flatten the curve, #flatten the curve. And everyone was into that. And everyone kind of like that was the message. But then things have shifted a lot. And there were outbreaks in other parts of the country, right? Outside of the Northeast and sort of the West Coast. So these are all really important things that I think this public education part is so key.
Okay, we just have a few minutes left. Here's one. This may be a big question, but what metrics can we use to assess the operational effectiveness of contact tracing in an ongoing way? This person was directed it to Candice, but if anyone else has something they want to weigh in as well, I'd love to hear from the whole group about that.
Well, I think, you can do the assessment from right at the beginning and go down the line from beginning to end. So, what is the percentage of positive tests. How many positive tests do you have? How many of you called within 24 hours? How many of those did you successfully get a realistic number of contacts? From those, how many of the contacts did you call within another 24 hours? You could also have some quality metrics in there of the cases that you're calling. What percentage is willing to do to isolate, to make sure they stay home until they have, 72 hours without symptoms or a negative test. So like really right through to the end, so that you're staying in contact with them and you're following up with them until they are really finished quarantine or finished isolation. I think something that is really, really important is going back to people who've been through contact tracing and case investigation and getting their satisfaction levels. Understanding what the reputation of the contact tracing is in a community is really important. Probably much more important for sort of bigger state-funded contact tracing programs over local contact tracing. But those just really at the lower level, figuring out each of the success rates every step in the process and getting the quality. The other thing is, I think it's important to understand the satisfaction of the staff and do the staff feel like they are being effective? Because I think you can get a lot out of the contact tracing staff, and they will tell you if they're not being effective, if they're not getting the calls, if they're not getting the information they need, either from a testing organization somewhere within a contact tracing organization, or from the people they're calling. And so looking at all of those, I would want operationally to look at all of those to make sure we're doing our best and to problem solve and come up with solutions for any of those that are a problem. And they're all going to be a problem. So it's really about having the mindset that we're gonna find a solution, and we're going to improve it, all ongoing programmatic improvement all the time.
One last question. I think this speaks to the trust issue that has been a theme throughout the conversation. But this person asks, where's the data housed? Is it safe? And is it confidential? Elizabeth, maybe you can speak in concrete terms about just in your area in Alameda County, where's the data going? Is it safe and is it confidential?
The data is confidential. It's housed in a large Excel spreadsheet, and we are working with our data team here in our IT department to figure out a way that's more sustainable than an Excel spreadsheet that's becoming completely unwieldy. We also have a platform through UCSF called Atlas. I'm sure many folks on the call are familiar with. And so the data is housed in a confidential manner in our secure servers. It's transmitted securely to our partners, but it is, in many cases, like I discussed before, a manual process. And that is the element that's really unwieldy for us. And not having the interoperability between our different platforms is a real struggle for us right now.
Okay, and it's safe to assume that there's some variation by jurisdiction and state in terms of how they're storing this data and what security measures they're taking?
Yeah, that's a safe assumption. I'm not familiar with how other departments are managing their data.
Okay, great. Well, that's all the time we have. I think we could go for another hour. I have tons of questions, but thank you so much to our panelists for taking the time to have this conversation. And thank you to you, the audience, for listening and taking time out of your day to participate and send such great questions. As Brian mentioned, we'll have a recording of this available within a day or so. And I believe we're also going to try to make this available on the podcast that Mathematica puts out on the evidence.
Thank you, JB.
Thanks,
Thank
everyone.
You, Thank you.
Good luck, everybody.
Thank you very much. Thank you.
Stay safe and stay healthy.
Exactly.
Yeah, stay safe.
Be well.